right, so I'm excited to present this work. Of course, this is my fabulous team. Nobody works on the island. So we have many of our different staff, educators, psychologists. We even have data analysts on our team, which actually have been pivotal for some of the work that we've been doing to improve CGM access in our patient population. So of course, Sagi showed this chart before, so we understand that, we've made improvements in A1C as reported by the Type 1 Diabetes Exchange. Even at our center at Cincinnati Children's Hospital, we've made strides in improving our A1Cs across the entire population. But we understand that Type 1 diabetes outcomes are marred by key disparities in many different groups, including those of Black race, Hispanic race, those on public insurance. And so nationally, morbidity and mortality, of course, in Type 1 diabetes is grossly marred by these disparities and equity gaps. And locally at Cincinnati Children's Hospital, we recognize that Black youth with Type 1 diabetes and those on public insurance have a significant gap in their A1C outcomes, as you can see by that graph. And so we also understand as endocrinologists that continuous glucose monitoring, as well as other forms of diabetes technology, can drastically improve diabetes outcomes, including the endpoint primary A1C. And so we see that the key disparities are not only marked by race, they're not only marked by insurance type, but also they're marked in CGM access. So Black patients with Type 1 diabetes are less likely to use diabetes technology. And although I don't have the graph here, that holds true for our public insured patients as well. And so, of course, we dove deep to try to understand where these equity gaps lie. And so this is our key driver diagram. And of course, any equity intervention has to be multifaceted, multidimensional, and multidisciplinary. You can never do just one thing to change the outcome. So we have many different interventions that we use to drive and increase CGM access across our patient demographics. I give homage to Don Cunningham, who actually introduced us to this RAIL, which is a Rolling Action Implementation List, which is what we use essentially to really organize the work that we were doing, right? So not only do we have our key driver, our intervention, our PDSAs, but we actually have the individual people whose actions item they are, and then we have progress towards those goals. If you have any equity project, this is essential. All right. And so back to our key driver diagram, and I'm going to show you one of the key drivers, which was consistent and equitable care for the CGM. And this was the rail that it was associated with. Basically, what we had is a no CGM list. And so we had our data analysts, again, very pivotal in this work, help us to define a list of patients that were not on CGM who were having clinic visits come up. And our amazing diabetes educator identified those patients, did a kind of a validation to make sure they were actually not on CGM because the list wasn't always right. And then she would actually go to clinic. And we had developed already in our Epic healthcare system barriers to diabetes technology. And so she met with the patients, assessed their barriers, documented it. And as you can see, we actually made progress toward those goals in those patients that did arrive to clinic and introduced them to CGM technology by addressing those specific barriers that they identified. Probably our most successful intervention, or the one I'm most proud of, is our stories from our patients, so our voice of the customer. Of course, we can never do any work when it comes to equity without listening to the patient themselves and understanding what their own barriers were. And so this was the key driver diagram that it was associated, the intervention was associated with. This was the rail that was also associated with. And then this was actually the video that we developed from our patients, actually, that we identified, who had essentially been hesitant to start continuous glucose monitoring and then started and then discussed their outcomes. Their QR, we don't have time today, but you guys take the picture of that QR code. These videos are actually live and on YouTube. So you can actually see each one of them. We had 3 different sets of videos from our patients. And again, this is the probably my most favorite of our interventions that we did. And we're going to be having this play for our patients in our waiting rooms. There's access to it online as well, and then on our own internal hospital website. Of course, there are so many different things that we did, right? We can't really even talk about all the things that we did, but we have now CGM at diagnosis. We, through the help of Abbott and Dexcom, we have a sampling program. We've created a shared decision-making tool to help with increasing access to technology. We now have on-site access to technology. So our pharmacy now carries our CGMs, and our DME company in the next 2 weeks will go live carrying our devices as well. And then, one of the newest and most popular diabetes devices, automated insulin delivery systems, you have to have a phone to start, right? And unfortunately, some of our patients don't have a phone, or if they do have a phone, they don't have a compatible phone. So we're actually worked with one of our creative phone solution companies to try to improve phone access to our families. All right. And so with all the work in our interventions, we actually are seeing some increase in the percentage of patients that are using continuous glucose monitoring. There's still a gap, but we're beginning to close that gap with the multifaceted, multidisciplinary, and multidimensional interventions that we had thus far. And you can see that on some of our PDSA cycles. This probably doesn't capture everything. And we didn't just work with Dexcom, we also worked with Abbott. We just hadn't noted it on this graph here. And then, as you can see, the insurance type probably has the closest, greatest of interventions in reducing the equity gap amongst insurance. And I will say probably the single most important intervention, and we're actually trying to figure out how to delineate this, was open access to CGM technology on our Medicaid that happened in July of 22, I believe, right? July of 22 was open access to diabetes technology across Ohio, all Ohio Medicaid. So I'm great, but that was even better. All right. So pretty much, we know that there's a disparity that exists in the outcomes of patients, and we know that there are. Do these patients, all want to be healthy? Of course they do. Are they counting on us? Of course they are. And then do we want to help them, stand beside them and fight for them? Of course we do. And so with all the work that everybody's doing across these equity gaps, we just need to understand that this is the long game. And so we still have high rates of hospitalizations amongst our patients, despite increasing CGM access. And so we still have a lot of work to do. Now take questions.
All right, there in the back.
To get people to kind of progress to technology. What are your thoughts as to why those people were on the no CGM list for so long, and what is it that the educator is doing? Is it the luxury of time? Is it something about their ability to motivate and counsel patients that gets them to overcome the barriers?
So that's an excellent question now. So I'll repeat those for those online. So the question is about how, when we had our no CGM list, what did the really educator identified as the barrier to the CGM technology in the first place? Well, I have the luxury and the benefit of having the educator right here in the room. So if somebody could give the mic to Amanda, who is my CDCES, who actually was the one who authored the list and did the interventions.
Yeah, I think the biggest thing was that having the devices in front of you to show them what they're looking at and to understand what their barriers might be. We have many solutions. It's just a matter of having the conversation and taking the time. So I think just that focus in the clinic on that specific topic and just trying to troubleshoot, like, how can we overcome these barriers? And then this is just try it. We don't have to say we're doing this forever. Let's give it a chance. And then having the samples from the companies and clinic made a big difference because we could offer real-time training and education. What was the second question?
And the second question is, are the video testimonials by the patients publicly available? Or is that...
Yes, yeah. Yes, the videos are publicly available. So if you missed the QR code, I mean, I can go back and you have access and you can show them in your clinics. We work with our media and branding. So Cincinnati Children's Hospital will be all over that if you're showing it.
So Nana, I have a quick question for you. So what was your goal in terms of reducing the gap or the inequity for the project? How did you set that? And then second, how did you target your interventions? Because one would assume that if you do certain systematic things in the system, everyone will get better. but did you prioritize particular barriers for particular populations?
So for the first question, I always am hesitant when we create our first, aim, right? Like reduce the number of patients hospitalization and reduce this from this percent to this percent, because it's arbitrary. Literally that the number that we decided was at 80%, we would increase CGM access for Black patients with type 1 diabetes from, 50 some 30 to 70%. Those were arbitrary numbers. Like you just picked them out of there. Okay. So I can't tell you there was a systematic way in which we developed those numbers. And then the targeted interventions. So the way that we decided which one to tackle was kind of like, which ones can we do the quickest and fastest, and which ones are going to take time. So like for the EPIC request, right, that's going to take a little bit of time. But for this no CGM list, since we have a data analyst, he was able to fairly quickly get that list to us, and so that we can do that intervention. So, and then there were some interventions that we were already starting to do, so that like the CGM sampling program was already beginning up and running at the time. So then of course we would use that as part of our interventions of things that we were already doing. CGM at diagnosis was already, the talks of that were already beginning to happen. So then we incorporated that as well as one of our interventions. We recognized the phone program as an issue, and actually it was one of our CGM companies that actually made us aware of what we call a Pulse RX program that actually gave phones to Medicaid patients. So then we partnered with them to have that intervention.
Fantastic. Okay, I think we need to move on. Dr. Sanchez, you're up.
Hello, everybody. So we're excited to talk about advancing equity and technology usage for our patients with diabetes. This button. So of course, everybody knows that even though technology is available, and even if you have good third-party payers, that there's racial and ethnic disparities exist. So we thought it was important to have set clinic policies where it's just the policy of clinic that would help us advance equity. And we started initially by having 2 focus groups, one with our Black patients and one with our Hispanic patients, to help us determine how we were going to do this. And we started with our CGM policy, and our policy is now place a sensor on everybody at diagnosis. And we do not ask them if they want a sensor, we ask them, which sensor do you want? And so it's just automatic that you're going to get a sensor. Of course, you have to work with prior auth. We've been hearing about that all morning to make sure that they can get their sensor. And then we'll try to have them continue with the Dexcom or the Libre, depending on which one they prefer. If possible, we'll try to get the insurance to help us with that. And then trying to match the sensor to what do they want, what are they looking for, what are they willing to wear, what can they afford, what their insurance will pay for, and try to keep up with that one. If they're indigent, and we do have, unfortunately, a fair number of indigent patients, we do have some of the free samples that we're able to provide a sensor, at least periodically. And some of the families that are paying out of pocket have realized that it's actually cheaper to get one of the cheaper sensors than to pay for all the strips. So they were actually willing to pay for one of the cheaper sensors and get that data. We also found that it was critical for the success of the sensor to have an adult following the sensor. So the more that we can get the parents seeing the data, sometimes the grandparents, sometimes it's the older sibling, and have them involved, that makes a big difference in getting the patients to continue using it. If they're not wearing the sensor, then at every visit, we're going to address, why are you not wearing a sensor? What are the problems with it? Going through the benefits of the sensor. If they were wearing a sensor and then they stopped, we can almost always show them the difference in A1C between when they wore a sensor and when they didn't. We will try to not let them leave the visit without a sensor on. And so that makes a big difference. If we can just put them on it the first time, the majority of them will continue using a sensor. We have now about a 95% sensor use, and we have about a 50% Medicaid population. So we're pretty proud of our sensor use with that. We also use the sensors a lot with our patients with type 2. If they're using MDI, we try to get a sensor for them. But even the ones that are using basal or GLP-1 agonists, We find that it's very helpful if they have a sensor and they can see what they're doing, their meals, their exercise, how that's working. Even if they're not willing to wear a sensor all the time, we try to get them to at least wear it periodically. A lot of times it helps if the other family members who have type 2, which is frequently a lot, if one of them wears a sensor and they see the benefits of the sensor, a lot of times then we can get the child wearing the sensor. Again, prior auth is the bane of our existence with sensors. We have discovered that for the most patients, if they're not wearing a sensor, it tends to be one of two reasons. Mostly is they don't want to wear it, or the second one is that they're having skin issues. So we find that those are the ones that we have to address right away to try to keep them on sensors. Then the next policy we did was in-pens. So we have a very high in-pen use. We try to get everybody to use an in-pen right after diagnosis. If we're not going to go to a pump quickly, to get them on an in-pen soon. We try to have them using the carb ratio with the in-pen, but you can use the fixed dosing. And we find that very helpful too for our patients that are unable to carb count, that at least we can track what they're doing. And because it has the sliding scale in it, they don't have to calculate that. And again, now we can see it. We can present the data to the parents to show, well, he's only taking a shot once a day. This is why the sugars are so high. That makes a big difference. We are able to work with our rep to be able to get the $35 in-pen. If they're not covered by insurance, that helps a lot too. And we have a project, actually one of my fellows, Dr. Figueredo, will be presenting that tomorrow on asking them to send us their in-pen report every month if their A1C is more than 8. And so we find that very helpful to be able to track that data. And then in terms of pumps, we try to start discussing pumps fairly early on. Once they've had diabetes, usually about 3 months, and have hopefully mastered the basics of diabetes. Ideally, their carb counting, depending on which pump they may be going on, that may become less of an issue. We try to review how the pumps work, the requirements for the pump so that they have a realistic idea of what a pump will do. And of course, we want everybody on a hybrid pump, so they have to be willing to wear a pump and a sensor. We found that's one of our biggest sticking points is the kids who don't want to wear both. And then we just found some tools to help promote technology. One of the key things we found was that it really helps to have a provider that speaks the same language. We have about 60% of our patients are Hispanic, and a lot of our technology use increased dramatically when we got our first CDE that spoke Spanish, and that was actually Hispanic. And we have more providers now that do speak Spanish, and that's made a huge difference. Trying to understand cultural reasons why patients don't want the technology, and that helped when we had our focus groups to see why people were opposed to it. Found it very helpful to get school nurses involved. Sometimes if they can kind of just get the same kids in the school together. I know this kid's on a pump, this kid's on a sensor, and maybe peer group that they can see each other using it. That really helps when you're not the only kid. And sometimes they think they are the only child in the school with diabetes. They're the only child doing these things, and that helps to get the school nurses. Sometimes the grandparents, the older siblings, especially for some of our immigrant populations, the parents who are not familiar with American technology or healthcare. Sometimes if we have a sibling that they'll be the one to convince the parents to let the child go on the technology. Sometimes we found out the problem is cost, that the copay is too high. So even if they have approval, the copay is too high, but they don't want to tell us that. So you have to kind of get that information from them. Sometimes they tell us they don't want other people to see that they're wearing a device. So we'll talk about locations they can wear it with. We'll get our psychologists in to talk with them, and we find that to be helpful. And then a lot of times they just need help understanding how do they do it, is it a DME company? Is it the local pharmacy? And trying to work with them, especially the ones who don't speak English, to be able to work through the system and to also get the schools involved. Thank you.
I had a quick question. In your in-pen thing, you said this helps explain why blood sugars are high. Is that going to get a kid in trouble? Isn't it better to help them remember to bolus than to catch them after?
Well, ideally, yes. But sometimes when the parents are, or if the child too is just like, I don't understand why I'm high. And you can point out look, clearly there was a spike here. Clearly there was a missed bolus, and not in a kind of punishing tone, but just an explaining tone. Like you can see, or just even like when you bolus late, that you can see, look, this is the spike. This is when you gave that. And the same thing with the pump, that you're just giving them the data and showing them this is what happens. And this is what happens when this was why you had a drop later on, was because you bolus late. And so, you know, we try to spend a lot of time educating them on how everything reads, and telling the parents, look at this with them so that you guys can do it together. And that when you see an unexplained high, go back and check your history. That's going to be your number one cause of a high, is that you forgot to bolus. And so we've just discovered showing them that data makes a huge difference.
I have a question too. So one of the things that you had touched on was putting CG on my diagnosis, which we're working on too, but not really giving them a choice. And we literally just had this discussion in faculty meeting, because I'm going to age myself, but you remember the days of NNR, right? We were giving patients a choice between NNR and multiple daily doses. And then finally we were all like, yeah, forget that. Everybody's doing multiple, multiple daily doses. And I feel like we're almost there. This pendulum is swinging that same way. So I wanted to get your perspective on kind of removing the choice from the patient, because we're so now driven by what the patient wants and what the patient needs, and how that dichotomy and conflict is resolved.
I mean, we just say it as like the beginning, you give people meters. I mean, you didn't ask people, do you want to check your sugar? Of course, you were going to check your sugar and you're going to have a meter.
Yeah.
So it's like, this is the standard of care. This is what is the standard of care now. So we try to present it like that. The hardest group we have getting on is the kids who've had diabetes for 15 years and just, I don't want to do it. And that's the hardest group to get doing any of the technology, I find sometimes.
I will say, as an adult endo who has these patients who weren't put on these technologies at diagnosis, for you peds endos out there, if you could do that, that would be great.
So I have a question about that. So great, you've not given a choice. What sensor are you going to get on? What do you do with those people who have DME, who can't get it through a pharmacy channel, who are having to wait 30, 60 days to get on a sensor? Are you giving them samples to last that long?
So we try to give them samples. So usually within 30 days, everybody's on. So, I mean, our nurses spend an enormous amount of time working with a prior auth. So most of the time it doesn't take 30 days, and we will try to cover them if we have enough samples for it. What depends now is that we're at what the mercy, whatever they give us. Right. So sometimes they give us something that doesn't go with their phone. And so sometimes that's where the issue becomes, and sometimes they have to switch back and forth. I mean, listen, I'm going to give you this one, this 2 weeks, and then the next 2 weeks is going to be a different one.
So I think there was a question in the corner. Yeah, if you want to, can you introduce yourself and your institution, just so everyone has situational awareness of the audience?
Sure, thank you. Zoltan Antal from Weill Cornell, New York Presbyterian. My question is also sort of a comment on this. I remember when we transitioned our patients from NNR to basal bolus, there was a lot of diabetes distress that we didn't pick up on until families came to us and said, well, now we're thinking about our carbs all day long, and we're carb counting all the time, and we only had to do this 2 or 3 times a day. I think that same step has happened with technology, where we acknowledge the benefits of technology, but not the distress that it places. You know, some people have a pod failure every day. And so they're putting on 5 pods a week instead of 2, whereas that's how we imagine things to be. So I think that in addition to all this, which we totally support, we're trying to figure out, and we would promote for our diabetes distress index, and to monitor that, because there's probably some balance between the two that we need to strike.
Yeah, we're fortunate. We have our psychologists very involved in clinic, and we have a quite extensive survey that's done. Goes through a bunch of those questions. So that a lot of times they're the ones who come to us. The psychologists say, listen, they've answered this in this survey, that they didn't tell us that was the problem. And so that then, because they've answered that, we're able to address it.
So I want to actually move us along, because I don't want to run out of time. Dr. Cymbaluk, if you want to go next, and hold your question for the next round, because I'm sure that these topics are universal and keep coming up after every talk.
Okay, so I'm Anna. I'm from Rady Children's in San Diego. Let me see. The big one. Huh. Got it. So this is along the same lines. So me and my colleagues over in San Diego, we were focusing on specifically insulin pump utilization, and our publicly insured patients, you'll hear me call it Medi-Cal because that's what we call it. So just for ease of speaking. So I don't need to tell or belabor this point. Obviously, we all know that technology, including insulin pumps, is known to improve our glycemic outcomes. And with any new tech, we end up kind of finding significant socioeconomic disparities. And so for what it's worth, public insurance is often used as a proxy for our socioeconomic status of our patients. And so our specific SMART aim was to increase the amount of patients that had Medi-Cal insurance from 30% to 40% in just over a year. This work was done in part through a really lovely course we have at Rady Children's called the QI Leadership Course. It used to be focused mostly on young faculty. It now involves some of our nursing leadership. And so we basically work through the QI process, come up with projects together, and kind of go along all of the different processes of a QI project. So as you can see through the key driver diagram, there's many different things that we all think about as far as the ultimate goal of improving our diabetes related outcomes. I want to sort of just show you our big run chart and kind of go with you through the different interventions and results. So my lovely team was actually working on this when I didn't even work there. So I was lucky enough to sort of join the project in the last summer of 2022. But previously, just for some context, our pump class at the time throughout this whole run chart you see in front of you was sort of the gatekeeper to the process. So if we had a patient that was interested, they would go to the pump class that was taught by our lovely educators that are in the room with me. So throughout the process, we started really focusing on, okay, how do we eliminate us as providers as the barriers? And so you can see that the first intervention that happened was we actually included some of the pump class information as well as just basics on pump technology in this huge binder that they get at diagnosis. So that way patients could, in theory, show up to clinic and be asking us about the pump rather than waiting for us to bring it up to them. A large amount of our patients speak Spanish as their first language, and so we then added a pump class in Spanish. At this point, all of these classes were virtual. So this was sort of 18 months to 2 years into the pandemic, right? We had sort of switched everything to virtual and stuck with that. So these were interpreters that were logging on to the Zoom line with our educators. We then, one of the interventions was that our clinic nurses, those that don't teach the class, but the other set of, 8 to 10, were not feeling as comfortable having these discussions with families. So again, we wanted to just spread the word. So all of our clinic nurses were then educated on pumps. We tried to increase access by just having more virtual classes. Something that's not noted here is these classes were 3:30 to 5 o'clock via Zoom. And that will be relevant when we talk about next steps. So we were having, 3 to 4 classes a month, one of which was at least in Spanish. And ultimately as we were collecting data, figured out that some patients were taking the class, but they were not taking the little post-class assessment. And so we figured out that part of that was because our platform for the class was Zoom through MyChart, but they were getting the assessment through an email link. And so we were able to leverage MyChart as a way to sort of have it all be integrated. So they obviously already knew MyChart well enough to log on to the class. And so that then becomes a message that's automatically sent while they're completing the class to complete the test. It was also a good way for us because then, you can click the box that says, let me know if this isn't read in X amount of time. So we were able to make it easier for us to see who was falling through the cracks. I had the lovely task of being the newest faculty member to present to my new colleagues about provider bias. Thankfully, they're all very malleable group of fantastic faculty. So, there's some data to support that one of the biggest things that's known to impact your bias for diabetes technology is just time and practice, not necessarily your age. So if you went through the process of becoming an endocrinologist later in life, you're less biased than someone that might have gone straight through and has been in practice longer. So bless them. They did not send me too many dirty looks, and they were actually very, very open to it. But yes, that was a big part of one of our interventions, was just talking to them about how, hey, we have a role in this too. We need to make sure that we're not gatekeeping this technology, I think maybe is a way that we used to think about it. One of the other things that we started doing was specifically following up with patients about, hey, why haven't you taken the test? Or why did you not choose to go on a pump? Sometimes it was like, oh, I forgot to take the test. I'll take it. I want an Omnipod. Thanks. Other times it was, hey, I took the class. I actually decided, no, thank you. And we'll continue to, revisit that with them. And so as we came along, we certainly met our goal. We sort of hovered up and down, and thankfully we're ultimately able to show to our institution that, we had met our goal and we're able to secure some additional funding. But what's, I think, most important about this work is that it actually really informed, we changed the whole process after this. I think largely we had met some of our basic goals, but I think we kind of came as far as we could. We got as far as we could with what we had. And so we've now shifted into having a little bit more of a pre-pump class curriculum, meaning that there's certain education points we want our patients to already be doing. For example, they should all be using insulin to carb ratios before they show up to the class. They should actually understand the types of insulin and the risk of DKA. And so we've really shifted the focus to empowering our providers as well as our clinic nurses that are doing this education in the clinic of, do you feel confident that they understand the difference? There's no basal on board now, risk of DKA, how to troubleshoot these things, so that when they show up to the class, which is now, by the way, in person on a Saturday, midday, in our clinic waiting rooms. So the way that we're leveraging that is they're showing up and we're projecting the PowerPoint onto the TVs in the waiting room. So we have bigger capacity. We are getting families in person. And so when they show up, they're not learning about what a pump is for the first time. They are fine-tuning kind of what the different tech looks like. They get to talk to one of our more senior educators about sort of what may work better for them. So they show up to the class better informed. One of the other things that we've taken, thinking from a health equity lens, we really weren't satisfied with interpretation over the phone on a virtual class. We still offer the virtual class for those patients that are not able to make it to our clinic on a Saturday. But we now have an option because we are, I think, not laboring our educators as long to do these Zoom classes during the day, but they actually have opened their schedules to do one-on-one education. So we're capturing the ones that are right for the in-person Saturday class or the virtual class with a little bit more pre-pump class education. And those that need tailored education, anybody that's not English speaking gets a one-on-one with one of our educators to go through the process. But we also have kind of the option of, if as a provider, you're filling out the pre-test readiness form that we've created, you can say, hey, doesn't matter, why, but this is more appropriate for a one-on-one. So happy to report that past these, our most recent numbers have been closer to 50% actually. And so I think if this project taught us anything, it was like how far you can get with the low-hanging fruit, and then where do you go? At some point you have to recognize, I think we've probably done as good as we can. So that's, like I said, we were up to 42% this summer. We're now upwards closer to 50, and we're continuing to track this data of our Medi-Cal patients. So, we learned quite a bit, I think mostly just informing the next steps of always thinking through the health equity piece, making sure we're truly focusing on those who need it, rather than sort of just continuing to benefit people that always benefit from new technologies. So this is my lovely team that are here with me, so you'll see their faces, but I'm happy to answer any questions y'all have.
So one old point I just want to throw out from the last talk, Dexcom, I know, makes a sheet because our educators keep it laminated to show your old patients who are used to their meter, the differential in the glucose readings, Dexcom versus finger stick, because that's a barrier for a lot of people. When one says 300, the other says 360, they feel like the Dexcom's broken because it's new, right? So we trust what we know. And so for a lot of the older converts, having that understanding of the normal range is helpful. And then just to add on to the diabetes distress increasing with the more things we do, which is true. I also find myself frequently finding kids who have manifested a lot of phone issues because they don't want their parents getting onto them about what they do see on their apps, whether it's InPen or Dexcom. And so reminding everybody, especially with their higher risk patients, to have those conversations about how the parents can decrease the child's distress and how they choose to respond to the alerts they get. And then in regards to the pumps, I just want to raise a question that I feel strongly about. And I feel like we all need to challenge the pump algorithms, and that I don't agree that every patient who ends up on a pump that's not iLet needs to actually carb count specifically. If you find a lot of people with diabetes for a long time, most people guesstimate a lot unless they have a label in front of them. And so I find that when you make the necessity of carb counting mandated before you go onto these other pumps, it is a barrier for some of our higher risk, more challenging patients. And I'll often bridge them with small, medium, large meal doses. And then of course they have a carb ratio plugged in. So if they have a label, they can type it in and it can be educational, but I don't love the idea of programs prohibiting pump use for ones who don't carb count.
We, of course, right when we finished our readiness sheet, iLet came out. And so now we're like, what are we gonna do about that? Because we can't say you have to know how to do ICR. So yeah, it's always in flux.
Denise Dalton from Helmsley. Why is your presentation on pumps and not AID?
That's a good question. I'm looking at my team because they originated this process before I showed up. Do y'all remember? Yeah. Yeah, because this process started before even like Omnipod 5 was available to our Medi-Cal patients. So I think we kept it just as pumps alone, because I think up until midway through this project, our Medi-Cal patients couldn't get on Omnipod 5 even if they wanted to.
Right. So I think we're moving into a realm
Yes.
that no one should be wearing a pump and a CGM
Agreed.
without.
And I don't think that, for what it's worth, any of these patients have prescriptions for those things unless they're looping and they're still on the dash. But it's all Control-IQ and it's all Omnipod 5 otherwise. But
Okay.
good question. Yeah.
Great. And one other question, and this goes to the other panelists previously presented too. So we have a study that is CGM uptake, increasing CGM uptake in PCPs in Colorado specifically first. And a lot of the barriers, because of prior auths and all of that, initiating CGM has been a very big issue. But CGM Pro, which is Dexcom now has it unblinded, has been a way to get quickly CGMs without having to deal with the prior authorization, at least start, and then like deal with the reimbursement work. So I was just wondering how much of that practice is common or not common, or you see it as an option or not an option, or if so, why not?
I can talk about that a little bit. So we used to use Pros a lot, the Libre Pro and the Dexcom Pro. It was a great tool, but the office has to pay for it. So, and the money coming back with, billing for the interpretation. Okay, yes, but they had to come back to the office to then get that billing code. So that was like a clunky system. Now we still have them in our clinic, but we've ditched it because we get demos. Yeah. And I can say demos, not samples, demos. Yeah. So that's what's working.
But I think I want to acknowledge that I'm in an institution where we can't give out anything for free. And if you have a teddy bear, right? Really, they're going to take everything away. So I think it is complicated for centers that don't have that option because it's just a non-starter. And then I will say for Pro, because of the administrative complexity of setting anything up that relates to billing, you just bank on getting people onto their CGM as fast as you possibly can because it's just not worth the work. Yeah.
We have the luxury of being in San Diego where Dexcom is based. So we're best buds.
I think there was one more question.
I had a question over here. Sorry.
Okay.
I know, I'm sorry. Hi. So my question is, and this is something that I experience a lot. This is Marissa from Cincy Children's and Children with Diabetes. With these systems and trying to get everyone on these systems, what we're seeing with our lower socioeconomic groups is an incredible challenge in having compatible devices.
Yeah.
And it's also creating a huge inequity when it comes to certain closed loop systems that require a smartphone
Yeah.
that is compatible to even get into hybrid closed loop.
Mhm.
And I just want to know if other centers, like what are you all doing to help bridge that gap? Is it simply providing the education that they have to have a phone with that system to achieve closed loop? Because I know other centers are like not even offering that system. Like, I don't know what y'all are doing.
Yeah, we're having those discussions, but just hearing Dr. Jones speak, I think we may need to think about, we have some, people that have donated, and I think that might be a good way to leverage their donations, is to like get the access to that technology in our kids' hands. We don't have anything standard right now, but you're right. Like I always tell our patients, and our education is very much set up like you should pick the pump that you want. You shouldn't have to pick the pump that you have to pick. And so some of those are a little bit more technology dependent, but I can't speak to, we don't have anything standard in place. I don't know if anyone else does.
I will just say, this is like my social justice hat. Like we got to yell at the tech companies. Like this is a problem, right? So I tell them all the time, you want us to prescribe your products, make the products usable for everyone. Like there's a product right? This is product engineering. So I've actually at least talked to, I won't name names, but at least one insulin pump company has been open to me talking to their engineers and be like, why did you make this decision? They're like, oh, we never thought about it. Right. So there's a lot that we think that the tech companies may be doing that they don't even realize that they are. Right. So again, T1D Exchange as an institution now, an organization, does have advocacy power, and we should be talking to the tech companies. There aren't that many out there anymore. So
Yes,
that too.
sure.
Yeah.
Right. And then, or, wanting to use the phone as a disciplinary action. I've had that come up a few times. So like the mom's hiding the phone in the bathroom, which communicates through the wall to the son's pump while he sleeps. So she can get the alerts and it can be closed. It can be loop. Yeah. So correct. He's not allowed to have the phone for his own privileges. So I thought that was creative, but you have to have a small enough house.
All right. So I want Dr. Chao to jump up because we got to keep going. We got to keep moving and finish by 12:30. So.
I'm going to be talking about the same topic, a little to 120 miles north. So it's good that we're in the same healthcare system and environment. So I'm going to start by talking first briefly about the landscape of the population we serve. So at Children's Hospital Los Angeles, in 2022, we serve about 1,800 patients with type 1 diabetes. We provide care to a diverse population that is primarily publicly insured. So you can see that 31% of our patients identify as white. I can't even see my own slides now. My vision is so bad. I think it says 3 or 5. I think we provide 3 to 5% of patients who identify as Black. About 41% of our patients self-identify as Hispanic. About 60% of our patients are publicly insured. Majority of our patients speak English. We do have about 13% of the patients who speak Spanish preferred at home. 45% of our patients are on pumps, and about 60, oh my gosh, I really wish I could see. I think 69% of the patients are on CGM. So I won't belabor our conventional pump workflow. I will go into a little bit of detail in the next several slides, except to know that we want to do better for our patients in terms of getting them on pumps. So our main problem was we identified that the median time from a provider referral to getting a pump to when the patient starts the pump is 136 days. For some families, that could be 40 days. For some patients, it could be 180, or multiple referrals are needed before they get started on a pump. We analyzed the data and found that if you're privately insured or if you're English speaking, you have a much higher odds of getting started on a pump. So our objectives was to develop a new pump referral process, improves the throughput, and to reduce the referral time from referral to pump start by about 15% or 20 days. So we identify many barriers to this fishbone diagram. I won't belabor them. I'll highlight just a few main ones. So one of the ones that we thought was the main barrier was that historically our center has focused on optimizing glycemic control before allowing someone to go on an insulin pump. While that may make more sense in the old days before AID, in the days of AID, that just really does not make sense anymore. Some other barriers include that we don't have a consistent process to say when is someone clear for a pump. We don't have one standardized process and how long that process is. We also don't have enough manpower. So our nurses do the nurse care managing power, and there just aren't enough of them for our patient population. And families often also have encountered very unique barriers, be it through work, through school, are not able to make the expected phone calls that we ask them to make. So our conventional process involves a clinician making the referral, then they're assigned to a particular nurse to do case management. The nurse works with them through collecting a detailed glucose log that includes not only glucose, but carbohydrate intake and the insulin doses so that they can help determine the best insulin doses and potentially settings for them. Once they are cleared, then there's the authorization process. Once they're authorized and have the pump, they come to CHLA for an in-person pump class, and then there's the post-pump management. So in our new process, we recognize that one of the main pain points is we don't have enough nurse care manager to manage all of these patients and the inconsistent process. So we develop a new workflow that focus on those. So in the case management portion of it, we added a pre-pump class that we call the Intro to Pump class. This is given virtually, delivered in a group format, and it talks about the realistic expectations of what can be accomplished through a pump and the care that still needs to go into wearing a pump. It also introduces the different pumps that are available and the technology. For example, you need a compatible cell phone. So we kind of talk about that in that pump class, and that is taught by in-nurse virtually. And then we removed the goal of having glucose logs. We removed the goal of having optimized glucoses. Instead, we have 2 set phone calls. So one with the nurse to basically touch base to identify their current diabetes self-care practice, acknowledge any, complete any, discuss any knowledge deficits that they may identify. And then a second phone call to check in with the family. What pump did you decide on? Do you have any additional questions? We are still requiring glucose logs, but everybody is on a CGM. So we just use those CGM reports to use as glucose logs for the purpose of authorization. And then after they attain authorization, then we added support from our nurse care manager to provide the additional support. So we used to do inpatient, our center practice is inpatient class, in-person class, and then we moved to a virtual class format where the class is now taught by the trainers and the pump trainers. So we have a nurse practitioner who does a pre-pump visit with them, determine doses based on their glucose sensor reports, address any questions, and then another check-in after, and those are all done virtually. So this is the baseline characteristics of our patients. We collected data from September of 2022 to patients who were referred through March of 2023. In our conventional pathway, we had 63 patients. In our new pathway, 34 patients were enrolled. There was no difference in the breakdown in sex, in public insurance, in their mean age, their diabetes duration, or their race composition. So to show you the outcome overall in the conventional process, 23% of our patients moved through the process within that time period. And in the new process, 55% of the patients were able to get on a pump. By insurance, if you have private insurance, it doesn't really matter which process you were started on, you have just as good of a chance. But if you look at our patients who are publicly insured, those who are publicly insured did much better in our new process and eliminated a lot of the barriers that prevented people from getting on a pump. We did not make an improvement to days to pump start. Those dates were comparable. I think one of the possible reasons could be that this was a pilot process, so we were not having classes as often as we would like to do. And we also added a medical management quiz / knowledge check. So because now the class is done virtually, we wanted to assess whether virtual learning versus in-person class learning resulted in any differences in their knowledge acquisition about insulin pump and safety. And we saw a trend that they did a little bit better with the in-person training. So to summarize, our new pump start process improved start rate for patients. And this occurred primarily in patients who are publicly insured. Unfortunately, the median time to pump start did not change. So our future process involves identifying the processes that we need to modify to reduce that pump start date. And we also need to have equivalent pathways for families who just learn better with in-person training. We also need to develop processes that are suitable for our Spanish or non-English speaking patients. And that's it. Thank you.
I love your idea, like calling after that initial pump class to follow up. What was the duration between the initial pump class and the nurse following up? Like how many weeks or days or months?
So we have a coordinator first call so at the end of our initial class, we do have a survey that asks them some questions, knowledge check things, and then we ask, are you interested? And then if they don't respond within 1 to 2 weeks, then we call them to set it up. The phone call follow-up, we try to do it, I believe right now we're trying to set it up within 2 weeks. So before, the nurses were playing a lot of phone tag that led to a lot of frustration. So now the nurses provide a list of time slots. These are the times that works to speak with me. And sometimes they're early in the morning, sometimes the end of the day, to make it a little bit easier for our families. And we thought that ended up working out much better for everybody.
Okay, I think that's great because it's like some families may not follow through on the application, or it's too cumbersome and they don't complete it, or with Omnipod going to pharmacy, then a PA is needed and pharmacy never notified us. And so I think that's a great idea to like help bridge that gap to moving towards public.
Yeah, but I mean, we can't do this work without a clinic coordinator. So unfortunately, I think everybody has the same issue that not everything we do is billable. Unfortunately, so we need institutions to invest in the manpower to support those important staff members.
How much coordination is done with the patients themselves? I know you're in pediatrics versus from the adult perspective, a big barrier for us is catching the patients again, whether it's on the phone or through MyChart messages or getting them back in person. I have many patients who say they have their pump supplies and the trainer can't reach them. So just, I guess, how much is done coordinating with parents versus the patients, and then follow up. It looked like the training was done by the staff in the center versus, this training was done by the pump companies. Thoughts on having the staff do it?
So the first question, all of our contacts are with the parents if they're under the age of 18. So the great majority of the contact is with the parents themselves. We do have people who don't answer phones. That's part of our barrier in terms of trying to use, for example, the Dexcom to support our patients in starting CGM, but then our people don't answer phone call. That's a separate problem. Your second question is why not do the training on site? So we historically have always done them on site, but we have also getting a lot of requests from patients who feel comfortable with virtual training and they don't want to come to the hospital. So I think eventually we want to work toward having clear pathways for families who want to come in person, who follow maybe everything else up to that point virtually. And then for those who want to do it in person, then allow them to do it in person. But we had to do it phase wise. And so we're still early in the adaptation. We initially started with one nurse care manager. Now we're spreading with every nurse care manager. And then I have our next goals and how to expand that.
Okay. You've been waiting to speak, and then
Okay.
Dr. Agarwal, if you want to come up while she's.
All right, Ilona from Penn. So your new process obviously got a lot more people through. Do you think that some of the residual is related to how long the process is, or what would it take to sort of get the next level of people, like even through the pump process? Because we also have a lot of people who kind of fall off and we're unsure as to whether our target should be getting them through sooner or, despite all the facilitation with the insurance, despite all the facilitation, with the family and with the patients getting them ready, they kind of still don't go through. So what are your thoughts about that?
Something that our nurse care manager have shared with us before is that clinicians are very eager to start everybody on pump, but once they start talking to the family, sometimes patients are not ready at that point. So I think a lot of, probably about half of our patients who attend the class, they say they're not interested. They're not ready at that point. But I think we do try to continue having that discussion in clinic so that maybe not now, but maybe in a few months.
Great, thank you.
Okay, I have the privilege of being the last speaker and you guys are all starving and don't want to hear this. But hopefully I'll wake you up a little bit because as you can see, I'm not going to talk about technology today, even though I do that all the time. So my name is Shivani Agarwal. I'm actually presenting on behalf of Priyanka Matthias, who is getting married as we speak next week in India. So I'm here to present our long-term results of hospitalizations from the SEED program, which is a Supporting Emerging Adults with Diabetes program. And we specifically service underserved young adults with type 1. So by way of background, so hospitalizations for young adults with type 1 have increased by actually 40% in the US in the last decade. This is from a recent paper that just came out in 2021. And for those of you that work with this population, young adults, they are at highest risk for many complications, including hospitalizations during the transition from pediatric to adult care. And so there's decreased clinic attendance, there's a prolonged transfer from pediatric to adult care, there are personal social constraints of young adulthood, and then gaps in health insurance. So and then obviously diabetes-related hospitalizations will increase healthcare costs. So we wanted to examine whether a specialty young adult T1D program, which I'll talk about, reduces hospitalizations. Like Nana was saying, we did not have a smart aim for this because we did not know how much we could improve or wanted to improve hospitalizations. We just wanted to improve it. So we don't have a specific smart aim. So I will say, I'm presenting the results now. This looks more like a research talk than a QI talk because this is coming from years of QI methodology that have resulted in both this program and some of the programming that we provide in the program. So the SEED program is a comprehensive program for young adults. There's this 18 to 35-year-olds. We basically offer kind of transition support from pediatric diabetes care. And then we have a lot of people who may have not made that transition or transfer well. They're in the ER, they're showing up in the ER, they're in primary care. So those patients we're getting also into this program and kind of integrating them back into specialty care. They may have been out for 5-6 years from having seen any endocrinologist. So this is the SEED team. None of these people are grant funded, which I'm very proud of. And you can see here some of our SEED team members. So Michael Greenberg is here. Okay. So what we do, so this has been published prior, but basically our program model as we provide, I should say this is an adult receivership program. Okay. So we're an adult-based transition program. So we do continuing education. We recognize that not everyone can be kind of wrapped up in a bow with what they're going to know about diabetes management, and that's okay. We also offer behavioral support. So we have been lucky that our institution has given us a psychologist for help. We do many sorts of kind of engagement and care activities. We try to do programming, but honestly, just trying to keep people in care. We obviously are partners with our pediatric colleagues. We do a lot of care coordination. A lot of our patients will have complications already. So ophthalmology, nephrology, sometimes cardiology, it's all over the place. And then we do some orientation to adult care and just kind of management and setting expectations. So some of the work that has, the QI work that has gone on in the past, for the past few years, is part of the SEED model. So technology forward care. We're very proud of our institution. We have a lot of kind of clinical pathways to get prior authorizations for technology expedited. We have worked with very specific kind of community-based pharmacies and DMEs that will deliver our products to our patients, help with training. So we've really done a lot of work on the technology front, both for CGM and for AID. And then social needs support. I was talking about this earlier. If anyone kind of noticed that So a lot of the patient voice came into this work where people needed help with their social needs, right? So we weren't going to talk about a CGM if they didn't know where they were going to sleep tomorrow, right? So we got social needs support, a lot of re-education, and then, like we said, psychological support. And our goals of care are not to bend A1Cs, are not to improve blood sugars. Our goals of care were to talk to patients, make sure we were being equitable in the care and the kind of humility that we gave to our patients. We managed expectations, we built people up. We kind of emphasized positives and managed the negatives, right? But we just wanted them coming back to care. That's what we wanted. All right, so for this analysis, we included all young adults in the program from January 2019 to December 2022. This was a prospective cohort design. So we were comparing young adults in the SEED program to young adults who were within endocrine at Montefiore, but just not in SEED for whatever reason. There was no kind of referral bias per se, but they just didn't end up in SEED for some reason. And our outcomes were diabetes-related hospitalizations, as well as days spent in the hospital. We used an EMR poll for this. And so it's kind of hard to see, but really briefly, this just gives you a flavor of who our patients are. This is very representative of the Bronx. So average age was about 25, equal split of male and female, predominantly either self-identified non-Hispanic Black or Hispanic, so about like 60%. And then you can see also publicly insured about 50%. And their A1Cs were in the 9s. That was like average A1C. Okay, so getting to the punchline. So when we look at incidence of hospitalization, you can see that our SEED patients had a lower incidence of hospitalization over the time that we studied them over the last 4 years. And that gap between non-SEED and SEED was actually most pronounced around 2 years of time of them being in care. You can see here just the numbers. So there was a 20% reduction in hospitalizations in the SEED patients versus the non-SEED young adults. And you can see, though, that when we categorize them by A1C over 9% versus below 9%, the greatest benefit was actually for those patients who had A1Cs, baseline A1Cs over 9%. So you can see there was actually almost a 40% reduction in hospitalizations for those patients. Hospital days also, so there was about a half a day difference in hospitalization when people were hospitalized. And that may not seem like a lot, but for that family that's trying to get out each hour that they wait in the hospital, it means something to them. And it also means something to the hospital itself. So every hour is a lot of dollars. So we actually made everyone happy with this metric. So conclusions, the young adults with type 1 receiving care in SEED versus the non-SEED were 20% less likely to be hospitalized, spent less days in the hospital, had a more pronounced benefit for those with an A1C over or equal to 9%. And our improvement in hospitalization outcomes obviously could hopefully have these long-term impacts. We're hoping that some of our interventions with the QI collaborative have really, borne true for these outcomes. So all of the work that you're doing will hopefully actually lead to this. That's it. That's all I got. Yes.
Denise from Helmsley.
Hi.
Who pays for SEED and how did you?
The institution.
The institution. And because of the outcomes, they will continue to pay for SEED?
Yep. So I haven't actually told any of you yet, but this is my group here. We just had we've now fed these results back to the CMO of the hospital, and they are really, really happy with this, obviously. And so they actually want the SEED model to go to GI. They wanted to go to all of the kind of rheumatology, all of the different service lines, because they think there's a model here. So they're willing to pay. What we don't have is like a clinic coordinator, or like, we're trying to borrow money and time from other people, which is what's made it sustainable. But they may hire a clinic coordinator for us now with the money.
Thank you for your presentation. I appreciate what you were saying about managing expectations rather than bending A1Cs. We do have a lot of our providers that feel very data-driven. A lot of our stuff comes on the tail of US News, and they say they hate feeling like they have to hit a parameter or reduce a number. So I'm going to take that back to our group.
Oh, great.
Thank you.
Okay. Does anyone here, like you guys are seed providers, some of you, do you want to talk about your experience at all? Or what seeds taught you? Not to put you on the spot.
Sure. So Michael from Montefiore. It's been a pleasure to work as part of the program. It's really just a good group of people to work with who have like-minded goals and expectations. And really what I'm trying to do in all my visits, and full disclosure, I have type 1 diabetes myself. I share that with patients who are willing to listen or seem somewhat interested. And the idea is that I just want to connect with them and really keep them coming back. And if you can connect with them in any sort of way, then I think the numbers will follow. But really, let's keep them coming back and keep them engaged in their care. And that doesn't happen in one visit. It doesn't happen in 2 visits. It happens with the overall team that we're working with. And I'm fortunate to be part of it.
Yeah, thank you. I would
Okay,
say also-
just want to acknowledge the great work by this all-female cast of improvers. So I think it's lunchtime, so I'm gonna let you guys go. Thank you so much.